talk about thyroid carcinoma, which is a scenario which is extremely important from a pediatric endocrine perspective. I largely touch base about how to approach thyroid nodule in particular, because therein lies the importance of identifying it at the right time. And then how do we manage from that perspective? So this will be the way we'll go forward. So thyroid nodule could be extrathyroidal in the form of teratoma or cysts, which usually you do not need to be very much worried about. You may have a thyroidal swelling, which may be benign. Most common cause, of course, is adenoma. Think of thyroglossal cyst, but this is not really that benign because there is a risk of infection. There's a long-term risk of malignancy. You might need to go for surgery in that regards. And of course, ectopic thyroid. And then, of course, you can have a malignant lesion, which could be papillary, follicular, medullary. We'll touch base a bit later about these conditions subsequently. Now, when we are assessing a child who comes to us with a thyroidal swelling, the key question is, what is the malignancy risk? So the history becomes very, very important. You have to record about how long the lesion has been. Has there been a progress? Has there been a family history? So a lot of factors have to be looked into in terms of history, a careful clinical examination, assessment of thyroid functions, nuclear scan, ultrasound, and FNAC. And we'll discuss about the role of each and every parameters one by one to identify what is best in that regards. So you have to go for history of head and neck radiation, which is often obvious. So if there is a total body irradiation, if there is irradiation, particularly for a neck region, lymphomas, which is less common now these days. And if there is a family history, which becomes really important for the medullary carcinoma, which we'll subsequently discuss about that. Examination again will give you a clue. So if you have a lesion which is bigger than 1 centimeter, remember this 1 centimeter figure is largely coming from the adult extrapolation. But in scenarios wherein we have got in terms of the pediatric age groups, in smaller children, you may be more worried or visual in that perspective in lesions less than 1 centimeter as well. If there is a rapid progression of lesions, or if there are fixed nodules you need to worry about, if there is involvement of the local area like invasive lesion like vocal cord paralysis, or a clear-cut cervical lymph node, you need to really worry about in that regards. MEN2 is a common familial association which may have other clinical manifestations which you can identify, would be skin lesions like mucosal neuromas or amyloidosis, which can be there. There are other parameters which we'll discuss a bit later, like Cowden syndrome or Carney's complex, in which perioral pigmentation and hematomas may give you a clue. So head-to-toe examination, as is important in any part of pediatric endocrinology, would become relevant also in this perspective in that regards. And this is important from that perspective. Now, TSH level also, of course, becomes important, gives you a clue. And very important to understand that higher the TSH level, the greater is the risk of malignancy. So if your TSH is very low, which means there's a functional lesion, the risk of malignancy is low. But as the TSH level is going up, the risk of malignancy goes up. And that also is important because TSH is a very, very potent stimulus as far as the thyrocyte to grow. So if you have any lesion which has a tendency towards growing more, if your TSH is high, there's a risk of malignancy. And this brings us to a very, very important issue, that if you have somebody who is exposed to radiation, exposed to chemotherapy or radiotherapy, and you have a TSH which is marginally elevated in the subclinical hypothyroid range between 5 to 10, this is one indication where you will treat, because you don't want the TSH to be high so as to increase the risk of malignancy. Similarly, post-management of particularly the papillary and the follicular carcinoma, you want to maintain the TSH level on the low range so that the risk of malignancy is not very high. So TSH in the initial evaluation will give you a clue. If the TSH is less than 0.1, it's usually an autonomous lesion. You should go for a nuclear scan. You should also go for an ultrasound. Final aspiration is usually not required, and we'll discuss about that when it will be required in this scenario. If it's 0.1 to 1, this is an interesting scenario. It may or may not be an autonomous lesion. And in this regards, usually FNA is not, and scan is not really recommended. But there could be one possibility that if you have an ambiguous result on FNA, that is, if you have a category 4, which is there in terms of the FNA, you would really be worried about in that scenario. And then you will go ahead with FNA in this scenario, because here you will have to decide whether this is an autonomic lesion or not in this perspective. Similarly, if you have a TSH which is more than 1, the autonomy becomes extremely unlikely. Of course, this means that this is a sort of a non-functional lesion. There's no role of nuclear scan. So nuclear scan is only indicated if your TSH is 1 or below, and that to below 0.1 definitely. Otherwise, you can be a bit judgmental as to whether you require a scan or not. Now, ultrasound, of course, becomes important in most scenarios that we are discussing. And then based upon the radiological features, which I'll touch base upon, you may need to decide about whether a FNAC is required in that perspective or not. Now, thyroid scan, as I said, is largely done to identify a functional lesion. And in this scenario, you may get different pictures in this regard. So if you have what is known as a hot nodule, which basically means that you have got an area of increased uptake, which is largely there in one particular area, and the other remaining area, you don't have any background activity. This is an autonomic nodule. There is no need for FNAC. You should go ahead with control using beta blockers, maybe iodine, maybe antithyroid drugs, and then go ahead for surgical intervention in this perspective. On the other hand, if you have this interesting scenario of uptake in all the regions of thyroid and one region the uptake is less, this is a highly worrisome situation. This is what is known as a cold nodule, and you have a very high risk of malignancy. So this is where you should go ahead do FNAC in that regard. Now, very importantly, if you have increased uptake on technetium, some people talk about use of iodine 1, 2, 3 because that will give you more information about that. And if you have a clear-cut hot nodule, then probably this is not recommended. Now, you should also understand the limitation as far as thyroid scan is concerned, because when you're looking at thyroid scan, you are basically looking at a two-dimensional picture. So if there is an area of increased uptake, which is hiding the area of not increased uptake, you may see, okay, every area is full and active and you may miss a nodule. So this is a two-dimensional picture. And as we talk about DEXA scan and peripheral quantitative CT in terms of the scenario for the assessment of bone density, similarly, this 2D, 3D becomes important in this perspective. So in scenarios wherein you have got an increased uptake in one particular region, but the remaining region, the uptake is not completely suppressed, and this is what is known as a warm nodule. This is a cause of concern. And here you should go ahead in this regards to a FNAC in that perspective. So even if you have a suppressed TSH, if you have a cold nodule or a warm nodule, FNAC still becomes important. As I said, ultrasound pretty much is indicated across board in this scenario. Now, ultrasound is becoming a very, very important modality to look for in terms of the thyroid nodule assessment, and most decisions with regards to FNAC will depend upon two factors, the size as well as the internal characteristics. And we have got specific TIRADS criteria, which are well established, which give you the risk of malignancy, particularly in adults. Pediatric cutoffs for these scenarios are not very clear. So we'll not go into the exact TIRADS criteria. We'll look in the overall picture to decide about whether this child will require FNAC or not from that regards. So pretty much ultrasound is required in everybody who has a thyroid nodule. It gives you information which is three-dimensional. So you can look into a posterior nodule, and also it will really clearly tell you this is a cystic nodule where you don't need to worry about much in that regards. Its role is largely to decide about the need for FNAC, and it can also guide aspiration. In children, generally we talk about ultrasound guided aspiration in most scenario. It can also confirm nodularity in a goiter. And as we were discussing about hypothyroidism, if you have a goiter and you're suspecting that this could be multinodular, get an ultrasound done, because the decision to FNA will depend upon the individual nodules which are there in a multinodular goiter. You can get the features which will predict the risk of malignancy and therefore the need for surgical intervention in that regards. And you can also identify a lymph node, or maybe there's some nodule which you're missing out in that perspective. Now, I'm talking mostly about the American Thyroid Association guidelines. Recent guidelines have also come in for the pediatric age group, which are pretty similar. So we'll touch base about in these scenarios. If you have a clear-cut risk factor like an irregular margin, if you have a taller than wide appearance. Now, this is a risk factor which is more for adults. It's not there for the pediatric age group. So don't worry about taller than wide. Look more for irregular margins, small internal calcification. So microcalcification becomes absolutely important. And if you have a rim calcification, in these scenarios, you are really, really bothered about in terms of malignancy. The risk is 70 to 90%. So you ask your radiologist to mention about the margin, the size, the calcification, vascularity, These parameters are absolutely important to decide about the need for the thyroid FNAC in that regards. However, if you have a lesion which has a regular margin, you have a 10 to 20% risk. The malignancy risk becomes less if you have a regular margin or you have hypo or hyperechoic area in that regard. So you have a solid lesion in which some part is black, some part is white. Think about 10 to 20% risk of malignancy, which is reasonably high from that regards. On the other hand, if you have a complete white lesion, which is hyperechoic, or similar to the other part of the thyroid, which is isoechoic, or if you have a combination of solid cystic area, the malignancy risk becomes less. So it's very, very important to not only go for size, because many times we get information about size, we also have to look at for features of the solid cystic area being present or not, calcification being present or not, the orientation of the nodule, and the heterogeneity of nodule, which will really decide about the need for further FNAC and risk from that perspective. Here, the malignancy risk is less, and then your decision to FNA will depend upon the size and other factors in that regards. If you have a purely cystic lesion, the risk of malignancy is extremely less. And in most of these cases, you can actually wait and watch in that perspective. So now, having discussed the overall prevalence and the risk factor as far as malignancy is concerned, if you have a purely cystic lesion, you can pretty much ignore the risk of malignancy. And in the scenario, also, if you have a lesion which is less than 0.5 centimeters, you don't need to do anything. If your lesion is 0.5 to 1 centimeters and extra thyroidal involvement is there, or there is compression or extrusion of the lesion from the thyroid capsule, this means invasiveness. So in small children where the thyroid gland is not that big, you may actually have these lesions which are becoming bigger, and this may cause confusion in that perspective. On the other hand, if you have a spongiform nodule, FNA is required if the size is more than 2 centimeters. If you have a scenario of, as I said, regular margins, isoechoic or hyperechoic, you can wait for 2.5 centimeters, and otherwise mostly it's 1 centimeters for most parameters. So except for the cystic nodule and the spongiform nodule, most cases would require FNAC. This is what I will say from our experience. Most lesions will be above 1.5 centimeters when they come to you. Most incidental lesions, on the other hand, will be somewhere around 1 to 1.5 centimeters, and therein the ultrasound becomes important. And therefore, to really look at not only the size, but also the internal characteristics becomes absolutely important from that regards. So just to summarize, if you have a lesion which is less than 0.5 centimeters, you don't need to do an FNAC. You can follow up in this lesion. If it's 0.5 to 1 centimeters with features of invasion, like extrathyroidal involvement, compression, extension, or a suspicious nodule, you don't wait, you do an FNAC in that regards. And often in this scenario, if you have a suspicious invasive lymph node, and often lymph node may be bigger than the lesion. Don't think that always the lesion will be bigger. If you think that this could be a metastatic lymph node, get an FNAC from that regards. If the size is above 1 centimeters, you should do an FNAC pretty much in most, especially if there is a solid lesion, irregular margin, microcalcification, or broken rim calcification, and above 1.5 centimeters if it's solid cystic lesion, and above 2 centimeters if it's a spongiform lesion. We are very soon to bring our second version of the third generation endocrinology application, in which there are many new interpreters which are coming up, and one of them is a thyroid nodule interpreter, in which you might have to just enter a few parameters about the size and these features, then will tell you the risk of malignancy and the need for FNAC from that regard. So it becomes much easier in terms of the use of those interpreters in that regards. If it's only cystic, you don't need to really do FNAC in that regards. So now, one important fact to remember is that if you are not doing a fine needle aspiration, always be wary that these lesions may progress over time. You may have seen them at an early stage of evolution. So you need to be bothered about that. So when do you follow up? If it's suspicious, but the size is less than 1, you don't think FNAC is not required, follow up after 6 to 12 months. If it's low or intermediate risk, you follow up after 1 to 2 years. And if it's very low risk, maybe 2 to 3 years. So just don't say, okay, don't worry, don't come back to me. Ask them to come back. Usually in our practice, we'll call them after 3 to 6 months. Because if you say 2 years, most of them will not come back to you. So better would be to call them after maybe 3 months. These are the guidelines. But then subsequently, you can call them a bit later. But I would say a 3-month, 6-month assessment for most will be important, even if you're not doing FNAC. Because if you say come back after 2 years, most people will not be back in that regards. Now, if you notice on follow-up that the size has increased, it has reached the criteria for the evaluation. So if you have gone more than 1 centimeter, you may need to do an FNAC. You need to worry about that. Now, final aspiration is the second most important aspect in terms of evaluation of a thyroid nodule after the ultrasound. And you have to understand that you're just trying to sample a particular tissue in a particular area. So this is something really to look at in that regards. If you have a lesion above 4 centimeters, if it's a large lesion, you may sample only a particular area and you may misdiagnose it. You may have a false negative result saying that, okay, there's no malignancy, but the other region may have malignancies. So the recommendations I choose from different regions if it's a large lesion in that regards. Very important scenario, if you have a multinodular goiter, you have to consider each nodule as an independent risk factor. So it's not that, okay, I'll just FNA the biggest nodule and forget about everybody else. If others also are indicators, you should do it from each and every nodule. However, if there are no other features, you can go ahead with the largest nodule, which will be the best way. Very commonly, you may get a non-diagnostic picture, which we'll talk about that. In that scenario, if you had not initially done an ultrasound guided, now recommendations are that for pediatric adolescent thyroid nodule, you should go ahead with an ultrasound guided FNAC. You should definitely do it if it was not done earlier. So as I said, in children, you should definitely do an ultrasound guided, or if there's a repeat one. If it's a posterior lesion, it's very difficult to identify. So better to go ahead with an ultrasound guided. And if you have a predominantly cystic, you may try to see, okay, this area is got more of solid area. I should take the sample from that regard. So FNAC is an important investigation, should be done in a center who are equipped with proper FNAC facilities and diagnostic facilities, which give results in terms of the NIH data, which I'll talk about. So the Bethesda classification, or the NIH classification of FNA, categorizes the FNAC into different risk factors. So you may have a non-diagnostic. You don't have enough sample. In that, the malignancy risk is there. So just because somebody has said non-diagnostic does not mean that there is no malignancy risk. There's a 5-10% chance of malignancy. You should repeat the biopsy, FNAC, or go ahead with a core biopsy if you are more doubtful in that regard. Some people say, oh, if it's a big lesion, let's remove it and you will get a much bigger picture in that regards. Now, if on follow-up, the size increases, the risk of malignancy is very high, and then you need to go ahead with the surgical intervention in that regard. If, however, you have a completely benign histology, the risk of malignancy is very less, 0 to 3%. In this regards, you should do an ultrasound after 12 months and do an FNAC if this is suspicious lesion or the size increases by 20%. So many people ask me, okay, how do we decide about that? So if your size initially volume, so go for volume, or maybe the diameter. If the diameter was 1.5 and it's become 1.8 and more, then you should definitely go ahead and do a FNAC. This is something which is important to understand. So size in terms of the linear diameter becomes more than 20%, or the volume becomes more than 50%. Now, of course, this is the cube of that. So around 50 to 60% will be the effect if you talk about the size increase in that regards. If you have category 3 and 4, and these are the most diagnostic confusing areas, so atypical area, lesion of unknown significance, or follicular lesion of unknown significance, there is a risk of malignancy which is high, more for the follicular lesion in that regard. So 10 to 40% risk of malignancy. Most people will do a FNA after 6 weeks. There are now clear-cut recommendation that if you do a genetic study to identify which genes are being expressed, you may get the more clearer picture in terms of the risk of malignancy. So you should do a molecular study. And here some people talk about doing a surgery also in that regards. Category 5 is suspicious for malignancy. Very, very high risk of malignancy here, 50 to 75%. So in this regard, you will like to do a surgery. And some people talk about do a molecular study if it's an invasive lesion. You remove a total thyroidectomy. If it's a non-invasive, less risk factor, you may go ahead with a limited removal or that particular lobectomy. So here molecular studies are also becoming important in that regards. If you have a clear-cut report of malignancy, the risk is hugely high, 97 to 99%. Surgery is definitely required. You have to do a total thyroidectomy. And I'll talk about how do we decide about subsequent management based upon that. So just to summarize what we talked about, in non-diagnostic lesion, the malignancy risk is there. So do a repeat FNAC or a core biopsy, and you follow up definitely in this scenario. If you have an increase in size more than 20% on follow-up, do a surgery. If it's category 2, which is more likely to be benign, the malignancy risk is 0 to 3%. Ultrasound should be done for follow-up. and surgery if the size is increasing by 20% or volume is increasing by more than 50% in that regards. Category 3 and category 4 are red herring. You have to worry about them. 10 to 40% risk of malignancy. FNA should be done after 6 weeks. Optionally, you can do a molecular study and consider surgery if there is a high risk in that regards. Category 5 is suspicious, a high rate of malignancy, consider surgery. And if you do a molecular study, which is reasonably fine, then you can go ahead with a lobectomy in that regards. If you have category 6, which is clearly a malignant lesion, with a very high risk of malignancy, you should go ahead with a total thyroidectomy.